Okay, so as we already discussed these ones, the breech presentation, cephalic version, when are you going to do the contraindication? The absolute contraindication is more important than the relative one. So just remember the absolute contraindication. If you remember them, then you are good to go. Moving on to the risk factors. What are the risk factors? Abruption, cord compression, cord accident, rupture of membrane, here. Labor, fetal bradycardia, and requiring cesarean delivery, alloimmunization. So all of these are the risk factors that can lead, that is actually leading towards the extracephalic version. So the methods is basically tokometry followed by the ultrasound. If the patient RH negative, then definitely giving ROGAM. Please do not miss ROGAM. It's a very, very, very important in obstetrics. Then better prognosis if multiporous. If unsuccessful, planned breech delivery right away. That's what you can do. So vaginal breech delivery can be spontaneous or assisted. Encourage the effective maternal pushing efforts, all these things. So usually what happens is in breech delivery, we actually refer the patient to the obstetrical. So on the basis of our knowledge, all we need to know is extracephalic version and when are you going to refer the person for the breech delivery. That's it. Coming to hypertensive disorders. Hypertensive disorders in pregnancy and diabetes in pregnancy is very important. Okay. Now moving on to the systolic BP more than 140 and systolic BP more than 140 and diastolic more than 90 is usually used for the pre-existing hypertension. If it's before 20 weeks, it means it's hypertension in pregnancy. But if it's after 20 week, it means this is the gestational hypertension. As you can see, prior to 20 week, it's pre-existing hypertension. If it's after 20 week, it's gestational hypertension. This after and before 20 week is everything. Without proteinuria in a patient known to be normotensive. So basically, if there is no proteinuria, this is basically gestational hypertension, only gestational hypertension. Preeclampsia, there is with the onset of proteinuria, or adverse condition like any end organ damage, not just the proteinuria. If there is retinopathy or there is anything that other organ is linked with or any organ damage happening, then this is preeclampsia as well. We usually just limit ourselves only to proteinuria. So they might can give you anything else, maybe give a heart condition or anything. Then coming to the eclampsia is usually associated with the seizures. So what happened is there is a convergence or comma in the existing of preeclampsia. So preeclampsia was already there. Along with that, now she experienced one of the neurological condition, which is basically conversion and comma or maybe any seizure attack. Placental malperfusion or any soluble factors into the circulation. So this can lead toward this one. So etiology is not important. Then epidemiology, there's a lot of people who actually suffered from this one. Clinical features is basically eclampsia, the clinical diagnosis. Usually convulsions can, if there is a hypertension history, along with convulsions, we go with eclampsia. Tonic-clonic and lasting from 60 to 75. They can ask you what kind of fits or seizures they can experience. So this is tonic-clonic. Symptoms that may occur before the seizures include the persistent frontal and occipital headache, blurred vision, photophobia, or any right upper abdomen or epigastric pain in up to 1/3 of the cases, approximately 25%. So usually they happen. Risk factors, primigravida, it's very, very, very high chances in the primigravida, 80 to 90%. So this is one of the most common cause of the hypertensive disorder in pregnancy. Which one is that one? Primigravida. Diabetes mellitus, chronic hypertension, renal insufficiency, obesity, APS, extreme of the maternal age or previous stillbirth or intrauterine fetal demise or vascular one. Fetal factors are IUGR, GTN. As I said, IUGR is there. Oligohydramnios could be there, GTN, and multiple gestation, fetal hydrops, and then abruptio placenta. So these are the risk factors for the hypertensive disorder. As you can see it here, hypertension disorders, adverse effects. You can just read this one or you can remember this one. Both are same. Now coming to the clinical features or clinical evaluation for the hypertensive, what are you going to start with? The body weight, because she might be obese. Central nervous system, maybe the patient is having headache for a very prolonged period of time and she's not noticing it. Visual disturbance, as I said, any end organ damage. So they can present with any of these things like presence of headache, blurring vision, trembleness, irritability, hyperreflexia, hematological or hepatic or renal. So anything could be there. along with the evaluation of the fetus. So usually in the CDM or in MCQs, they can ask you in hypertensive disorder, what are the evaluation of the fetus we do? So fetal movement, fetal heart rate, ultrasound for the growth, BPP, and then Doppler flow studies. So just highlight this one. This is important. Coming to the laboratory, what are you going to start with? Obviously, starting with the CBC, ALT, liver function test, and all of those things, because we are going to rule out HELP syndrome as well. Creatinine, 24-hour urine testing, and then can consider. So it's, you want to do it, you can. If you don't want to do it, it's up to you. May consider. Complication is basically HELP syndrome. So you have to rule out first the foremost thing, eclampsia, abruptio placenta, left ventricular failure, DIC, hemorrhagic stroke, IUGR in the fetus, prematurity, and all of those things. Management of hypertension. So if this is just the hypertension, you can start with the labetalol, right? For non-severe hypertension, what happened is target is 130 to 680. So this target is important. Please remember these values. Patient without comorbidities, because in the MCQs, they can just directly ask you in the hypertensive female, what is the target of the BP? So 130 to 80 or 130 to 155 to 80 to 105. Antihypertensive therapy for the both pre-existing and gestation, you are going to start with the labetalol. Usually labetalol is safe in everyone. If there is still contraindication like having pulmonary edema, asthma, those people, then you go for nifedipine. And if there is a contraindication, then you can go for methyl-dopa. For severe HTN, we go with the labetalol, which is given in IV. Nifedipine and hydralazine, same thing. No ACE or herbs or diuretics should be used. Then pre-existing HTN or gestational HTN without any deterioration. Then management of preeclampsia. Now this person is already having a one organ end organ damage. So first thing first, stability is important. No adverse condition is there. And making sure that the baby is doing fine and the maternal is also fine. Antenatal corticosteroid should be given in less than 35 weeks. In more than 35, delivery is recommended. If severe preeclampsia, stabilize and deliver regardless of the gestational age. Because if she's experiencing any of the certain like preeclampsia, like any end organ damage, this can lead towards the permanent damage to that organ. So that's why if it's very severe, then you can do the delivery regardless of the age. If severe preeclampsia during labor, increase the maternal monitoring, high overly input and output, overly neurological, and continuous fetal heart rate monitoring. Antihypertensive seizure is basically given MgSO4 if this is if there is a severe one and you think she might can develop eclampsia, then in those conditions you can go for MgSO4 regardless of anything. Postpartum management, risk of the seizure highest in first 24 hour of postpartum. So every 1 hour monitoring along with the HELP syndrome, most return to the normotensive within 2 weeks. So this is important. When can you estimate the normotensive BP in hypertensive or preeclampsia female? If the patient had already developed eclampsia. So in preeclampsia, we can go for MgSO4 and along with labetalol. But in the eclampsia, who had already developed eclampsia, starting with airway breathing circulation, because this is emergency. Roll patients into the left lateral position to prevent aspiration, supplement oxygen, aggressive antihypertensive therapy, prevention of the recurrent convulsions, MgSO4 in the first line, as you can go with that. Definitive treatment of the eclampsia is delivery, and mode of the delivery is dependent on the clinical situation and the fetal maternal conditions. So differential diagnosis of the cause of the seizure in the pregnant woman. Now, if you go by iron deficiency and folate deficiency, all you need to remember is the dosage of it. How much iron should be given and how much folate. Iron is 1 gram, folate is 0.4 mg. Coming to diabetes, what are the preconception and pregnancy management? Management is everything. Pre-plan and the refer to the high-risk clinic for the interprofessional care, because if this is already preconception, she's already having it. So before conceiving, you need to start with the management of the diabetes. Then starting with folic acid, which is 1 mg daily. So they can ask you what is the folic acid dose in the diabetic mother. 3 month prior to conception. Then glycemic control should be less than 7. Counsel and assess for the risk and complications. And then review medication. Coming to the pregnancy, if this is already pregnancy for second trimester, switch to insulin therapy, discontinue non-insulin therapy. So usually they said you can go for metformin, but it is controversial. So usually insulin is safe. If you have to choose in the options, just go for the insulin one. Tight glycemic control, insulin dosage may need to be adjusted on the pregnancy advances. At first different in the first trimester is different, in the second is different, and the third is different. Monitor as for the normal pregnancy plus initial 24-hour urine protein and creatinine clearance, then retinal exam, and then HbA1c. Increase fetal surveillance starting in that late T2 and T3, perform weekly at 34 to 36 week gestational age. Consider fetal echocardiogram. So usually for the fetal surveillance, what are you going to do is basically checking if the fetus is doing okay, if their heart is doing okay. So that's why fetal echocardiogram is usually done, because it's very common. They might develop any heart condition. Cardiac anomalies is very, very common. Now, starting from the 162A aspirin at night before 16 week of gestation to reduce the risk of preeclampsia. Postprandial blood glucose values seems to be more effective at determining the likelihood of macrosomia or other adverse pregnancy outcomes. Coming to the labor, timing of the delivery depends on the fetal and the maternal health and then risk factors. Induced by 38 to 39 week gestational age for uncomplicated pre-existing diabetes, induced earlier if indicated. So that's why if this is indicated earlier, then you can start with the 38 to 39 week. Why? Because macrosomia can lead towards a lot of complications. So that's why you need to consider this. Increased risk of CPD and the shoulder dystocia as of macrosomia with the babies more than 4 grams. So consider cesarean delivery. Monitoring during labor, monitor the blood glucose. As I said, it's very important because they can develop hypoglycemia. With a patient on insulin and dextrose drip, aim for the blood glucose should be more than between 4 to 7 to reduce the risk of neonatal hypoglycemia. Now, postpartum insulin requirement dramatically drop. That's why you have to do the insulin adjustment. Monitor glucose every 6 hourly. These things are very important. They can ask you how often you are going to monitor the glucose. So that's why monitor every 6 hourly. Return insulin in the 2/3 of the pregnancy. So screening and diagnostic, usually step 1 is perform a random non-fasting 50 gram OGTT, just remembering the main value. The 1 hour is less than 7.8. If just remember this one. If 1 hour post, if 1 hour glucose value is 7.8 to 11 millimole per liter, proceed to step 2. So if you remember 7.8 to 11, it can help you. If this 7.8 is less than 7.8 is normal, more than 11 is basically GDM. If it's between, it means this is kind of diabetic and it's kind of, you need to worry some. So step 2 is basically where you are going to perform a fasting of 75. Before it did was 50, now it's 75. Now you need to remember if it's more than 2 and it's more than 9, because we already know this is 5.3 and 10.6. But if it's more than 9 millimole, and if the value is different, like as we already discussed with the 51, it's 7.8. So if 75, and we already discussed this, doing this after step 1. So it means the value should be less than before one. So it's 7.8 in the first one, it's 5.3 in the second one. So remembering this one, the fasting plasma glucose is more than 5.3. 1 hour plasma glucose is more than 10. So it's basically it's diabetic. Or alternative one is 1 step screening of 75 gram. All you need to remember is this 51 and then 75 one, because rest of the things are kind of same. If you can remember these one, 7.8 to 11, because usually in the exam, they give the normal values, but for the pregnant females, it's very unlikely they might give you or they might not give you. So that's why, just to be on the safe side, remember the basic ones. So for the 51, it's 7.8 to 11. For 75, it's for the fasting is 5. And for the 2 hour, it's 8. Just remember this one. Management, first line diet management and increase the physical activity. Initiate the insulin therapy. Metformin can be used in pregnancy. but is off label. As we said, it's controversial. So we usually discussed with the patient if she wants to go with the insulin because it's kind of infusion. So most of the people does not want to take anything like IV or IM or subcutaneous. So usually they go for the oral one. So metformin, you can discuss the controversy with the patient, and if they still want to go with the metformin, definitely you're going to go with that. Then BPP and growth starting at 28 week. Starting at 36 weekly, you are going to check for the well-being of the fetus. Stop insulin and diabetic diet postpartum. Follow up of 75 gram, 6 week to 6 month. Labor, induction of labor 36 to 38 to 40 week, because if this is macrosomia can lead toward that. The complications are important because hypoglycemia is one of the most common complication and a lot of people missed it. Encourage breastfeeding for 3 to 4 months. Repeat testing for the female with the previous pregnancy affected by GDM. So they can have diabetic even after pregnancy. Metformin and glycerides are safe during breastfeeding. Other anti-insulin, antihypertensive should not be used. So which one is safe during pregnancy? It's basically metformin and glyburide. Now, complications of the diabetes in the pregnancy. What are those complications? As I said, hypoglycemia is one of the most common complication, but still, now, depending on the trimester, if it's before 20 week, like in the first trimester, there is organogenesis, right? So that's why the fetus is experiencing different type of complications in the first trimester, like occur in the trimester 1 and trimester 2. They will have cardiac diseases, as we said. Which one? Ventricular septal defect. Usually they ask what of the cardiac or heart congenital effect they can have. So ventricular septal defect, neural tube defect or gastro unit, kidneys, gastrointestinal, musculoskeletal. These are the ones because in the organogenesis is happening in the first and second trimester. That's why they are experiencing this. But in the third trimester, usually they just experience preterm labor or hypoglycemia, these kind of things. So in the mother, it's HTN because diabetes can be linked with that hypertension. So eclampsia, polyhydramnios is important, hypoglycemia, ketoacidosis, diabetic coma, retinopathy, nephropathy, so all of these things, pyelonephritis and other conditions. In the fetus, macrosomia, usually IUGR and organ maturity is delayed because of hyperglycemia. Surfactant is not able to do that. So RDS is one of the most common complication. Now, but hypoglycemia is still the first one. Then the congenital anomalies, because if it's happening before 20 weeks, it's different. If after happening 20 weeks, then it's different. Now coming to the labor and the delivery, preterm labor, prematurity, most common in the patients with the HTN. Preterm labor is associated with a poor glycemic control, increased evidence of the stillbirth, birth trauma, neonatal hypoglycemia due to pancreatic hyperplasia. That's why they are having hypoglycemia. And they can have, so this is important. After the birth, what are the complications for the fetus? Hypoglycemia, hypocalcemia. Otherwise, rest of the things are high. Okay, only glucose and calcium is below the normal range. Otherwise, bilirubin level is high, jaundice is there, and polycythemia is there. So that's why only hypoglycemia and hypocalcemia, hyperbilirubinemia and polycythemia. Okay, so that's it. Now coming to the early onset of the group B streptococcal diseases. What happened is the risk factors: prolonged rupture of membrane, more than 18 weeks. As we already discussed, the pre-prom is the one of the complication to lead towards the infection. And then coming to the maternal intrapartum GBS colonization, GBS proteinuria, and then previous infant with the invasive GBS. In those conditions, it's the risk factor toward leading towards the GBS. And then maternal fever, increased risk of endometritis, and increased risk of the vertical transmission, meaning leading transmission to the fetus. Offer screening to all women to 35 to 37. So we are not going to see only the risk factors. We are going to offer them to all of the female, regardless of anything. Vaginal and anorectal swabs for the GBS culture. Now coming to the treatment, prophylactic. When are you going to give the prophylactic? That's very important. Prophylactic treatment is basically usually penicillin. We'd give penicillin, and depending on the penicillin allergy, we give vancomycin and then clindamycin. Now, what are the risk factors and when are you going to give the prophylaxis? If there is a maternal fever, all the risk factors, usually all the risk factors. What are those ones? Maternal fever, broad spectrum antibiotic coverage regardless of the GBS status, and the gestational age is advised. If less than 27 week in the labor or with the rupture of membrane, IV GBS antibiotic prophylaxis within the minimum of 48 weeks. But if there is any of these risk factor present, just give the prophylaxis. Simple and easy way to remember. Because here this is written, indications for the intrapartum antibiotics, when are you going to give? Prevention of the prenatal, as you can see, previous child with invasive, as this is written in the risk factor as well. GBS bacteriuria, as this was also written here. Then during any trimester of the current pregnancy and even the previous pregnancy, there was a question where they said if the GBS bacteria was present in the previous pregnancy, are you going to give the prophylaxis in the next one? Usually, for me, the answer is yes. But in that question Q bank, they said no because there was a previous one. But if it was already been exposed to the mother blood, I think you can give it. But still, it's not written in the book. It says in the current pregnancy. So just stick with this one. GBS bacteria during any trimester of the current pregnancy. If it's current pregnancy, then you can give. Otherwise, in the previous pregnancy, it's kind of controversial. You can see based on the scenario what they're asking. And if you have an option, you can choose that one. Positive GBS vaginal and then rectal screening in the late gestational during current pregnancy. So they're talking about current pregnancy. Don't mix it up. I'm just letting you know because there was a scenario where they were asking about the previous pregnancy as well. Unknown GBS status, because, in the previous pregnancy, one of the justification they have given was because she had already received antibiotics, so they might have been fully recovered from the previous GBS. That's why they were not looking for the previous pregnancy. The current pregnancy is more important. Okay. Positive GBS vaginal rectal screening current in the late gestational during the current pregnancy, so usually in the current one. Unknown GBS status at the onset of the labor, so you don't know. Delivery at the less than 37 week, amniotic membrane rupture at more than 18 week, intrapartum temperature and intrapartum NAT test positive for the GBS. So in those conditions, you are going to do. Coming to UTI, increased urinary stasis from the mechanical and hormonal factors, organism include GBS as well. Then clinical factors, which is basically asymptomatic, dysuria, urgency, and then frequency, fever, flank pain, and costovertebral tenderness, just like UTI symptoms, any of them. Treat asymptomatic bacteriuria in pregnancy because it can lead towards the preterm labor. As I said, infection can lead towards the preterm labor. So even if there is an asymptomatic bacteriuria, you are going to give the treatment. Major organisms are E. coli, Klebsiella, Enterobacter, and then Proteus. Uncomplicated, you are going to give the amoxicillin. Amoxicillin is safe. And alternative is nitrofurantoin. The pyelonephritis, you are going to hospitalize and give IV antibiotics. Complications, if untreated, acute cystitis, pyelonephritis, and possible PTL. As I said, PTL is very, very common complication of any kind of infection. Then moving on to the infections during pregnancy. As in, the management is more important than anything else. Okay. So the chickenpox, the agent varicella zoster, just remember how does they look like. Okay. So in the fetus, this causes the congenital varicella syndrome. And the most important is preterm labor. I mean, if you can remember what are the congenital varicella syndrome, it's good. If you cannot, still just remember it can cause is basically cataract, like, eye diseases, because this is torch infection. So just remember the management. I think that's more than enough for me. So varicella zoster immunoglobulin for the female, but if exposed decreased congenital varicella syndrome, if maternal infection 5 days before delivery, give infant varicella zoster immunoglobulin for the passive immunity. So usually we don't give live attenuated, only immunoglobulins are given during delivery, as we already discussed this one. Cytomegalovirus, no specific treatment, maintain good hygiene, that's good to go. Then erythema infectiosum, like caused by parvovirus, hydrops occurs, considered fetal transfusion. Then feed hepatitis. What is that? You are going to give the immunoglobulin at birth after 1 and 6, as we already discussed. If the mother is already been having hepatitis B and or the unknown status, then you are going to give the 1 and 6 month dose as well. Coming to the herpes simplex virus, acyclovir is given. There is no vaccination for it. And usually suppressive therapy at 36 week. HIV, you give triple retroviral therapy, decrease transfusion. That's it. And elective cesarean delivery can be done. Then coming to the rubella, no specific treatment or for vaccination following pregnancy, like after pregnancy, because this is live attenuated, so we don't give vaccination. Syphilis, give benzathine penicillin. That's it. No approved alternative in pregnancy. If the patient is sensitive to penicillin, then desensitize and give penicillin. Don't go for different one. In syphilis, only penicillin works. Which one? Benzathine penicillin. Toxoplasmosis, this question is important. I have seen this Canada Q Bank, this benzathine penicillin in syphilis one. Toxoplasmosis, self-limited in women, spiramycin decrease the fetal morbidity. Influenza immunization with inactive influenza vaccination can be given. In infected, symptomatic treatment should be given. Coming to the venous thromboembolism, so treatment is basically low molecular weight heparin. That's kind of safe. Heparin is kind of safe more than warfarin. So that's why before initiating, do the CBC treatment with a low molecular weight heparin must be discontinued prior to delivery. How early? 24-hour prior to delivery. Then unfractioned heparin can be given, but you need to see it can lead towards the heparin induced thrombocytopenia. So repeat every 24-hour once therapeutic. So you have to give that patient IU, so just keep on repeating. So preferred one is low molecular weight heparin, so you can just stick with that one. If it's not in the option, then you can choose the unfractioned heparin. Warfarin is contraindicated as it can leads towards the teratogenic effect. VTE prophylaxis can be given in the female who has that steroid or has some sort of risk factors where the thromboembolism can occur. So that's why in those conditions you can give the prophylaxis. And prophylaxis is basically unfractioned heparin. Okay. In the treatment, it's low molecular weight heparin, but in prophylaxis, it is unfractioned heparin. So postmortem thromboembolism should be considered if the absolute risk is over 1. Current prophylaxis regime for the acquired thrombophilias. Now coming to the normal labor and delivery, what you need to know in this one is the normal general steps. Why? Because they can ask you after first step, what are you going to do next? Even in CDM question, they ask this question. So that's why. And the signs of the placental separation, gush of the blood, lengthening uterus, and then fundus. Let's suppose starting with the first stage, you are going to see if this is a latent one, this is active one. Second stage, you are going to start with the full dilation of the cervix, type of analgesics you are going to see, then the mother feels and then choose a comfortable position. Third trimester, baby's about to birth and placenta is about to come out, can last up to 30 minutes, gush of blood and all of those things you are going to mention. So they can what question they can ask is basically the fetus is out, like the delivery is already been done, placenta delivery is done, what is the next step you are going to do? So you are going to confirm that all the placenta is being out. So that's why you are going to check the all the cotyledons of the placenta to make sure that whole of the placenta is out. And after that, active management is basically start oxytocin. After the delivery of the anterior shoulder, you can give oxytocin, otherwise give after the delivery of the placenta. So that's why I said you have to, after delivering of the placenta, make sure that whole placenta is out, then give the oxytocin. So usually people miss out this part where you have to check whole placenta. Okay. Then routine oxytocin administration in the third trimester of the labor can reduce the risk of PPH. Fourth trimester, in the first postpartum labor, monitor vital signs and bleeding, repair laceration and ensure the uterus is contracted and all of those things. And let's suppose if they said the placenta is already out, and it's make sure that the placenta, whole placenta is out. Fetus is delivered, oxytocin is given. What is the next thing you are going to do? You are going to see the position of the uterus, if it's already moved back or if it's already in the below pelvic area. So that's why you have to confirm, like, doing the uterine massage and making sure that the uterus moved back. So that's why checking the uterus position at the umbilicus is important, doing the uterine massage. Okay. These are the very common question that comes from the third and the fourth stage. So just remember these ones. Analgesics and anesthetic procedure, just If you can go through them, it's okay. Coming to the fetal monitoring in labor, vaginal examination. So you are going to check for the membrane, if this is intact or not, amniotic fluid, if this is normal or not, then cervical effacement, if it's thinning, dilation, consistency, fetal presentation, where it is, and then body, pelvic size, monitor the progress of the labor. That's what you're going to do in the vaginal examination. Intrapartum fetal monitoring, what are you going to do is basically checking the fetal heart rate is more important. Fetal auscultation with a Doppler. Fetal heart rate is important. Use of a continuous electronic monitoring shown to lead to high intervention rates and no improvement in outcome. Technique is done, and then fetal scalp sampling. Usually we go should be used in conjunction with the fetal heart rate, but it's usually if CTG is done and it's totally normal, then we don't go for the fetal scalp sampling because kind of invasive procedure, so people go against this one. Coming to the fetal heart rate monitoring, fetal heart rate measured by the Doppler, contractions measured by the tachometer, described in the terms of the baseline fetal heart rate variability and periodicity. Baseline fetal heart rate normal range is 110 to 160 parameter of the fetal well-being versus distress. Variability, physiological variability is normal characteristics of fetal heart rate. Variability is measured over the 15-minute period and is considered an absent, minimal, or those things. So as we already discussed, the variability should be 6 to 25. More than 25 is maximum and less than 6 is minimal. That's it. Normal variability indicates that the fetal acid base balance, so it's totally acceptable. Can be used assessed by the electronic contraction by CTG. Then variability decreased intermittently even in a healthy fetus. Periodicity is basically acceleration or deceleration. As we already discussed, more than 15 for more than 15 seconds, it's for the 20 minutes. In 20 minutes is basically normal. In deceleration, it's decreased or less or latent one. So on the basis of that one. Now coming to the factors affecting the fetal heart rate. Now, if maternal factors, what are those maternal factors that can lead toward the tachycardia? All of the things that can increase the tachycardia. It's just the same. What are those things? Fever, anemia, hyperthyroidism, dehydration. As we in the normal individuals, these are the things that can cause tachycardia. In the fetal, arrhythmias, anemia, infection. So infection and anemia is one of the things that can lead toward the tachycardia. Drugs is symptomatic, and then uteroplacental is hypoxia or chorioamnitis, where the blood supply is decreased. Bradycardia, all of those things which can lead towards the bradycardia, hypothermia, hypoglycemia, hypotension, or the umbilical cord occlusion. In the fetus, dysrhythmias, hypoxia, all of those things where the blood supply is compromised. This can lead towards the bradycardia. So beta blockers, anesthetics, and then uteroplacental is basically late hypoxia, acute cord prolapse, and hypercontractility. Then decreased variability, infection, and then dehydration can lead. So it's mix of both. Dysrhythmias and then sleep cycle, preterm fetus, and then narcotic sedatives and hypoxia can lead towards the decreased variability. So just remember what are those factors which can lead toward the tachycardia and what are those factors which can lead toward the bradycardia. So approach to the management of abnormal fetal heart rate, how you are going to approach. So you are going to see the position. First thing, very common position because female is laying in the prone position. So that's why it's happening and there is a pressure to the fetus. That's why the fetal heart rate is compromised. So first changing the position, left lateral decubitus position, O2, IV fluids, fetal scalp stimulation, fetal scalp electrode, fetal scalp pH. So just remember the poison ER. So this can help you. P for position, O for oxygen, I for eye fluid, S for scalp stimulation, scalp electrode, scalp pH. Then coming to the oxytocin, O for oxytocin. So oxytocin should be stopped because it can decrease the heart rate. Then N for notify the physician. It means notifying some authority position like some supervisor. E for exam, vaginal exam to rule out any cord prolapse, and then R for rule out any fever, dehydration, and then drug. So that's why you are going to start with position, then oxygen, and then IV fluid. Usually you can just in CDM three things: position, oxygen, and IV fluid. But in MCQs they can ask anything. So just remember everything. as they can ask the patient or female was taking oxytocin, what are you going to do? So stop oxytocin. Comparison of acceleration and deceleration depending on the thing. So deceleration can be early, variable, and complicated variable, and then late. So you need to remember is early, variable, and late. You can skip the complicated one. And the most important you need to remember is basically their causes. What could be the cause? So early deceleration is basically benign due to vagal response to the head compromise. So all you need to do is reassurance. That's it. Coming to the variable one, due to cord compression, or in the second stage, forceful pushing with the contraction. So that's why it's happening. All you need to do is prolong. It could be the cause of the uh, prolonged delivery or prolonged labor. That's why it's happening. So you need to do the intervention right away. Late deceleration, use of the sign of the uteroplacental insufficiency. So it's an ominous sign. So you need to do something about this one as soon as possible. Only the early deceleration, all you need to do is basically this is benign. So you need to do reassurance. If you can remember, the complicated one is basically caused by the fetal acidemia. Just that. Rule out the 60 suggests is where variable deceleration to less than 60, more than 60 below baseline, or more than 60 in duration with the slow return to the baseline. So this is basically the SWARE variable deceleration. I hope you don't have any question up till now. Still, you need what I'm telling you, you need to remember these ones. If you still have more time, you can remember, or time to do whatever you can do further about these ones. Then fetal scalp blood sampling. Usually it is an invasive procedure, so there is so many complications and indications. So we usually don't go for this one. But let's suppose in the scenario of the ass cervix must be adequately dilated, indicated when typical and atypical fetal heart rate is suggested. Contraindications are blood dyschariasis like having hemophilia, or active infection like HIV, genital herpes, or hepatitis B. Fetal oxygenation, uterine contraction during the labor decrease the uteroplacental blood flow, which results in the reduced oxygen. So that's why uterine contraction can be one of the most thing that can, or most common thing that can decrease the oxygen supply to the fetus. Most fetus tolerate this reduction. So it's you can do the reassurance, and because of the prolonged delivery, you have to do the intervention right away. But if this prolonged oxygenation or hypoxia happened, this can lead toward uh, the permanent damage to the fetus. So fetal response to the hypoxia is decreased movement, tone, breathing, anaerobic metabolism, fetal bradycardia, followed by the fetal tachycardia, redistribution to the. So if the patient is feeling fetal bradycardia, you can do the reassurance. But if she start or fetus start having tachycardia, it means this is prolonged, and now you have to do something right away, because this if this goes on further, this can lead toward the fetal demise. Increase flow to the blood, heart, and adrenals, decrease flow to the kidneys, lungs, and the gut. So this is a kind of emergency situation, or kind of fight and flight situation, sympathetic situation. So that's why the blood supply to the brain and heart is increased. Otherwise, what happens is it's opposite. But right now, the body is trying to compensate. That's why the first thing that happened to is increase the blood supply. After that, if this is prolonged, then the blood supply to the brain, heart, and adrenals will be decreased. Increase in the blood pressure. Factors affecting the fetal, what are those ones? As we already discussed: anemia, hypotension, infection, abruption, any shock, any stroke, any these things can lead towards the fetal oxygenation compromise.